All right, everyone. So we're going to jump right into what does the future hold for treatment of atopic dermatitis. So as a review, atopic dermatitis is a chronic relapsing disease of the skin. Its onset is most common in infancy or early childhood, but it can occur at any age. Skin examination will often show erythematous scaly patches and plaques. Keep in mind that in skin of color patients, that erythema often has a reddish brown or violaceous hue. There is evidence of scratching, excoriations, and lichenifications often seen in patients. And the distribution usually changes with age. So typically in infancy, we're seeing the face and extensor surfaces involved. Think about when an infant is learning how to crawl. It's usually those extensor surfaces that are coming into contact with carpets and things of that nature. So that's why we see it often in those areas. Childhood and beyond, you're most often going to see those flexure surfaces involved. So those popliteal fossas, the antecubital fossa, the nape of the neck is a very common area as well. And atopic dermatitis can also be generalized or diffuse. Over 10% of the US population has some form of AD. The distribution is even among the ethnicities. Prevalence of atopic dermatitis in childhood is on the rise. In fact, 1/3 have moderate to severe disease, and over 16 million adults have atopic dermatitis, 40% of whom have moderate to severe disease. And 1 in 4 adults has atopic dermatitis symptoms reported with adult onset. So, years ago, we used to think that atopic dermatitis was a skin disease of childhood and you would grow out of it. But now we're actually seeing that that's not true. Many folks are getting the disease during adulthood. Unmet needs of treatment in atopic dermatitis are high. Specifically, there's a high level of disease-related burden despite current treatment therapies. So as you'll recall with my interview with Carrie Kai, she described to us how, as a bride getting ready for her wedding day, instead of being, worried about the venue and the guest list, she was also worried about her gown, not what's the most stylish, but what will cover her areas of atopic dermatitis should she have a flare. So there's that high level of thinking about the disease and how it would impact all sorts of activities for the patient. There's variations in response to treatment from patient to patient. So as providers, you know as well as I do that it's not a one-size-fits-all treatment for any patient. We have to really look at the patient, their specific needs, and how we can meet them and tailor-make a treatment plan that meets those needs. Loss of treatment efficacy over time. So one medication used over X amount of years may not have the same response that it once did. And adherence challenges. This I find to be in practice very cumbersome because patients are just tired. They're tired of constantly having to put on creams or take different medications. So it is important to address that as well. The great news, though, is that the treatments in the pipeline for atopic dermatitis are many. There's a robust pipeline. Today, I have the opportunity to talk with you specifically about 2 different classes of medications, Janus kinase or JAK inhibitors, and also additional biologic therapies. So when we're looking at JAK inhibitors, we're going to talk about oral JAK inhibitors and also topical JAK inhibitors. This diagram here on the right shows the JAK-STAT pathway. This is an intracellular signaling pathway that is downstream of cytokines that are critical in the pathogenesis of various inflammatory skin diseases, which include atopic dermatitis. You can see here at A, once a cytokine binds to its respective extracellular receptor, this activates phosphorylation of the JAK. Then here at step C, you can see translocation of the STAT proteins into the cell nucleus, where D, here in the nucleus, the STAT proteins regulate the expression of genes that are responsible for the synthesis of cytokines and other mediators that act on various cell types, including immune and skin cells. So this is a great overview of just how the JAK-STAT pathway works and why this is a new class of medications that are available, will soon be available for treatment of atopic dermatitis. So as mentioned before, this is a diagram of the JAK-STAT pathway. Some agents target individual members of the JAK family. So if we're looking at abrocitinib and upadacitinib, they're targeting the JAK1 pathway, whereas baricitinib is selectively inhibiting the JAK1 and 2 pathway. Now, oral agents may be more palatable for patients who are needle phobic, and all 3 agents are currently under FDA review, and a decision is expected in the second half of 2021. So now we'll talk about topical JAKs. Specifically, I'm going to review Ruxolitinib and Delgocitinib with you. They vary in their selectivity. So Ruxolitinib is coming in a cream form, and it targets the JAK1/2 pathway, whereas Delgocitinib is coming in an ointment form, and it will be targeting the JAK1, 2, and 3 pathways, in addition to tyrosine kinase 2. Both topicals have significantly improved eczema area and skin clearance compared to placebo in clinical trials. They have minimal adverse side effects and are well tolerated, and they're both currently under review with the FDA. Something to note is Delgocitinib is seeking indication only for adult moderate to severe chronic hand eczema. So next, we'll talk about biologic agents. And before we do so, I just want to review with you that a central feature in atopic dermatitis immunopathogenesis is dysregulation of helper T cell type 2. So you can see here on this diagram the Th2 here, and also the type 2 innate lymphoid cells. This leads to a substantial increase in type 2 immune cytokines, and those include interleukin 4, 13, and 31. So the next slides to come will be specifically talking about interleukins 13 and 31 pathways. So the new biologics in the pipeline are Tralokinumab, which is an anti-interleukin 13 antibody. Same with Lebrikizumab, anti-interleukin 13 antibody. And lastly, Nemolizumab, which is an anti-interleukin 31 alpha receptor antibody. So Tralokinumab, this is a humanized monoclonal IgG4 antibody, and it's neutralizing the interleukin 13. It's subcutaneous therapy, which is dosed every 2 weeks, and phase 3 trials are complete. They were tested both as monotherapy and in combination with corticosteroids. There's significant improvement in skin clearance, and itch was seen compared to placebo in all phase 3 trials. It's currently under FDA review, and a decision is expected in mid-2021. Next, Lebrikizumab. It's a monoclonal antibody that's binding IL-13. It's inhibiting the dimerization of IL-13R, alpha-1, and also IL-4 alpha. It's a subcutaneous injection, also dosed every 2 weeks. Its phase 2b trials confirmed efficacy and safety. Its dual phase 3 trials currently are ongoing, exploring the drug's use as monotherapy versus placebo. And last but not least, we have Nemolizumab. This is a monoclonal antibody that binds the IL-31 receptor alpha component. It's a subcutaneous injection that's administered every 4 weeks. And its phase 3 trials showed that the drug administered with concomitant topical corticosteroids and other emollients resulted in significant improvement of both pruritus and skin clearance compared to placebo. In summary, there's lots of new therapies that will be soon available for treatment of atopic dermatitis. They will be poised to be introduced, many of them later this year, and others. In summary, there are multiple biologic and topical agents that are poised to be introduced within the next 2 years for treatment of atopic dermatitis. They have several unique mechanisms of action. It is an exciting time to be a provider treating atopic dermatitis with so many new therapies soon to launch. But ultimately, it's going to be the efficacy, safety, and cost that will be primary considerations for patient selection. I thank you for listening in today, and I encourage you to look at more of our presentations under cases and commentaries of atopic dermatitis. For those of you interested in claiming CME credits, you'll need to now complete a short activity post-test and evaluation. Thank you.
All right, great.
How was it? Do I need to retake anything?
The one thing that I am going to ask you to do is, because I saw on this slide here, where I call these both creams.
Yes.
So I am going to both topicals, and I can see if our editor can make that change. But sure. if you can redo this slide,
sure,
that might also be a good idea.
Sure, absolutely.
So let me so just to give you some context, I think the slide before it was this. Well, you're talking about the oral JAKs, and then this is the slide on the topical JAKs. So I'm going to take everybody out. When you see the slide come up full screen again, that's your cue to kind of start again. So hold on. Next, we're going to talk about the topical JAKs, specifically Ruxolitinib and Delgocitinib. They vary in their selectivity. So Ruxolitinib is selectively targeting the JAK1 and 2 pathways, whereas Delgocitinib is targeting not only the JAK1, 2, and 3 pathways, but also tyrosine kinase 2. Ruxolitinib is coming in a cream form, whereas Delgocitinib will be in an ointment form. They both significantly improved the skin clearance as compared to placebo in phase 3 trials. They had minimal adverse side effects, and they're both currently under FDA review. One thing important to note is Delgocitinib is seeking FDA approval only for adult moderate to severe hand eczema. Perfect.
Awesome.
Great. Yeah, that was to be able to kind of talk knowledgeably and clearly on the JAK inhibitor slide like this one. That was pretty good.
Yeah, I'll be honest with you guys. I was learning along with you as I prepped for this. It was great because all of these are about to hit the market. So, I feel like I already have one up on understanding this pathway. And I think a lot of, derm PAs and NPs will be tuning into this. And I hope Nia is planning on launching it to them as well, because most of us don't understand this pathway. It's really only rheumatologists that are comfortable with it.
Yeah, for sure.
And I think I said upadacitinib. I don't know how to say this one, you guys. I tried to Google it.
They're always tough. I think it's, I know it's baricitinib because I've done work with that one before.
Yes, that one.
and then upadacitinib, I've done work with that, but abrocitinib is a new one to me too.
Yeah.
But I think it's fine. I think it's fine.
All right, good. Perfect.
Steve or Audrey, anything else on your end?
No, it's phenomenal, Archana.
Yeah.
Great job.
Thank you, Audrey. And thank you, Scott, for taking all my edits last minute.
No worries. Not difficult to do.
Awesome. Then do you need anything else from me at all? At this point, we're done with the patient interview and also the presentation. So I'll just look to see it launch.
Yep. We will be in touch when these all start going out for sure.
Okay, terrific. Well, it's a pleasure working with all of you. Thank you.
Same here, Archana.
You too.
Bye.
All right, bye.
It's a pleasure.
Yeah, and that one she actually was short, so that'll be
Yeah.
good. It'll probably come in at 30 minutes for this activity.
Nope. Nobody going into the spa today, Aud?
No.
No, that was good. She's good.
Okay.
She's
And,
good.
All right,
and
I will,
nicely articulated. All the
Yeah,
nips.
very good.
Yeah,
Very good.
yeah. So I'll put some instructions together for Mike, and he said he would work on it next week.
You got it.
All right,
Nice work, you guys.
strong. All right, kids.
All right, kids. Enjoy
Come
your-
see
On the golf course.
Yeah, that's not happening. I got 89 pre-test, post-test, and follow-up surveys to navigate through.
Oh, I feel terrible for you. I feel
Yeah,
so
I hear you.
terrible for you.
I hear you.
All right.